Good afternoon, and welcome to this case-based discussion on on the treatment of vascular access flow dysfunction, which is part of the vascular access course of EVC 2021. To participate in this workshop, also as a passive observer, you grab your telephone and make a picture of this QR code, because we will be using this to vote during the session. So you can actively participate even when you are not registered as active participant, but as passive observer. Please take a picture of this QR code and get ready to vote during the session. So this workshop will be done by me, Maarten Snoeijs. I'm the Vascular Access Course Director. We're happy to have Rutger Brands, interventional radiologist at Maastricht UMC. And then we have external tutors as well. Dr. Matteo Tozzi from Italy, who is joining us, and Dr. Jos van den Berg from Switzerland, interventional radiologist, who is also on board on our panel of experts on the treatment of vascular access flow dysfunction. And we will be discussing the endovascular treatment, which is probably done in about 90% of the cases of flow dysfunction. And
good afternoon.
What the contents of this workshop will be that we will first discuss the indications for treatment of flow dysfunction. I will show you a presentation on that. Then we will have a number of cases where you can vote and participate, and this will be a very interactive part of the workshop, so please get ready for that. And we will finish by showing some evidence on this new drug-coated balloon, the Aperto balloon, which has the results of a randomized controlled trial published just recently in the American Journal of Kidney Diseases. So, but first of all, let's get started about the indications for flow dysfunction, because this is a very critical aspect of treating this problem in hemodialysis patients. Please, video A.
This presentation was made by the Vascular Access Course Directors of EVC and has no conflict of interest. This presentation is a summary of the evidence on detection of vascular access flow dysfunction in hemodialysis patients. Flow dysfunction is the most common complication of arteriovenous fistulas and grafts. Flow dysfunction is caused by a stenosis in the vascular access circuit, may result in inefficient dialysis treatment and eventually lead to vascular access thrombosis. The vascular access stenosis is typically treated by percutaneous balloon angioplasty. In this presentation, I will discuss two different strategies to detect vascular access flow dysfunction. Monitoring of the vascular access is done by dialysis nurses to detect clinically apparent flow dysfunction that generally requires intervention. Surveillance of the vascular access requires additional equipment and is used to screen for asymptomatic flow dysfunction. It is currently unclear whether treatment of the vascular access stenosis is indicated for asymptomatic flow dysfunction. Monitoring is defined as the examination and evaluation of the vascular access by means of physical examination to detect physical signs that suggest the presence of vascular access dysfunction. Patients should be referred for correction of the underlying stenosis when signs of flow dysfunction are present. These signs can be divided into signs detected at physical examination of the vascular access, recurrent problems during dialysis, and unexplained sustained fall in dialysis adequacy. For each of these three domains, a number of objective clinical indicators can be formulated. Physical signs associated with vascular access flow dysfunction are a weak, discontinuous thrill with only a systolic component, a high-pitched, discontinuous bruit with only a systolic component, a hyperpulsatile vascular access without venous collapse on arm elevation, a weak vascular access with poor pulse augmentation at venous outflow compression. The bruit of a normal vascular access sounds like this. In contrast, the bruit of a vascular excess with flow dysfunction may sound like this. Here you can see a normal vascular excess with venous collapse on arm elevation. This is an example of a vascular excess with normal pulse augmentation at venous outflow compression. Recurrent problems during dialysis associated with vascular excess flow dysfunction are new difficulty with cannulation when this has previously not been a problem, inability to achieve the target dialysis blood flow at reasonable thresholds for arterial and venous pressures on the dialysis machine and when using adequately sized needles. This case-based discussion was made by the Vascular Access Course Directors of EVC and has no conflict of interest. Within 2 weeks before referral for correction of the underlying stenosis is indicated. Finally, an unexplained sustained fall in dialysis adequacy may be caused by vascular access flow dysfunction. Typical thresholds indicating the need to refer for correction of the underlying stenosis are Kt/V below 1.2 or urea reduction ratio below 65%. The various clinical indicators of vascular access flow dysfunction we have been discussing were based on the 2019 update of the KDOQI guidelines. Please recall that monitoring detects indicators of flow dysfunction that present clinical problems caused by symptomatic vascular access stenosis. In contrast, surveillance is used to detect flow dysfunction without clinical indicators that is caused by asymptomatic but hemodynamically relevant vascular access stenosis. Therefore, in surveillance the vascular access is periodically evaluated using hemodynamic tests. Several hemodynamic tests can be performed to detect a vascular access stenosis. The static venous pressure indicates the blood pressure in the vascular access when the dialysis machine is not running. In contrast, the dynamic venous pressure is the pressure in the venous outflow of the dialysis machine, typically measured at a flow rate of 200 mL per minute using adequately sized needles. Both of these pressure measurements are only useful to detect outflow stenosis that result in increased pressure in the vascular access. Another approach that can be used to assess hemodynamically significant stenosis in the entire vascular access is to measure vascular access flow. This can be done during dialysis sessions with dilution techniques or outside dialysis sessions with duplex ultrasound. Several randomized controlled trials have studied whether periodic vascular access surveillance and correction of asymptomatic stenosis improves clinical outcomes for hemodialysis patients. For this meta-analysis, we identified 10 trials with almost 1,300 patients, including more than 750 grafts and over 500 fistulas. The recently published HASTE trial could not be included in the meta-analysis because its outcome data were not reported in sufficient detail. The effect of vascular access surveillance was different for fistulas and grafts. For fistulas, vascular access surveillance had a trend towards reduced risk of access thrombosis with a relative risk of 0.57 based on 61 events. In contrast, surveillance of grafts had no effect on access thrombosis with a relative risk of 0.96 based on 231 events. The intervention rates with vascular access surveillance were 1 to 3 times greater than the intervention rates without surveillance. The trials included in this meta-analysis had substantial clinical heterogeneity, in particular with regards to the protocols for assessment of the vascular access and the threshold for referral to correct the suspected stenosis. Furthermore, in all but one trial, some form of surveillance was done in the control group to detect and treat access stenosis without clinical signs of flow dysfunction. Finally, the potential beneficial effect of vascular access surveillance in arteriovenous fistulas was based on only 61 thrombotic events. This uncertainty in interpretation of the evidence from randomized controlled trials is reflected by recent international clinical practice guidelines that reach different conclusions on the use of surveillance for vascular access flow dysfunction. Guidelines from the European Society for Vascular Surgery recommend to do periodic access flow measurements and suggest to take action when flow in arteriovenous fistulas is below 500 mL per minute, and advise against duplex ultrasound surveillance and preemptive correction of stenosis in arteriovenous grafts. Guidelines from the European Renal Association suggest that the evidence for surveillance of arteriovenous fistulas is inconclusive and requires more research, and suggest against surveillance of arteriovenous grafts unless it occurs in the context of a clinical study. KDOQI guidelines from the US National Kidney Foundation state that there is insufficient evidence to make a recommendation on surveillance of arteriovenous fistulas, and do not suggest surveillance of arteriovenous grafts to improve access patency. In this presentation, I discuss two strategies to detect vascular access flow dysfunction. Monitoring of the vascular access is done by dialysis nurses to detect clinical indicators of flow dysfunction. These indicators involve physical signs at examination of the vascular access, clinical problems occurring during dialysis treatment, or laboratory tests indicating insufficient dialysis adequacy. Flow dysfunction associated with clinical indicators requires intervention to correct the underlying stenosis. In contrast, periodic vascular access surveillance with hemodynamic tests can detect asymptomatic flow dysfunction. It is currently unclear whether treatment of vascular access stenosis is indicated for asymptomatic flow dysfunction detected by surveillance.
So, welcome back to the studio. I think that this presentation nicely summarizes how we can decide for which stenosis we should do a treatment and which stenosis can be left alone. The next step in this process is to discuss how we actually are going to treat this stenosis, and we will be discussing the endovascular treatment of these flow dysfunctions. So,
this case-based discussion was designed as an interactive training in decision-making during endovascular treatment of vascular access flow dysfunction. After presentation of a clinical case with angiography images, a number of interventional options are presented. Both active participants and passive observers are invited to take a stand and vote online by scanning the QR code. When you have made your decision, we will discuss the various endovascular strategies with the active participants and the panel of vascular access experts in the studio.
So I hope you can make your decision on this one. No need to share the results. Let's get ready for the first case. This is a case, a 61-year-old woman with a right forearm loop graft. We see what's going on with monitoring, as we've discussed in the previous presentation. Physical signs are a weak, discontinuous thrill and bruit. She has problems during dialysis. She's prolonged bleeding from the puncture sites. Dialysis adequacy is normal, and access flow has been measured and is 450 mL per minute using transonic flow measurements. For this clinically relevant flow dysfunction, we have made a duplex ultrasound, which shows that also in duplex ultrasound the flow is about 450 mL per minute. And you can see the configuration of the loop graft taking off from the brachial artery at the elbow and then looping around the forearm and eventually having the venous anastomosis at the cephalic vein just proximal to the antecubital fossa. And then there's a stenosis of 1.4 millimeters in diameter, halfway up to in the upper arm in the cephalic vein. We decided to do an angiography, and as a start point for further endovascular treatment, the sheath is placed in the venous side of the graft, and you can see the elbow joint, and we take another shot, angiography shot, a little bit more proximal, and here's here's I think the culprit lesion. So, Dr. Brands, could you maybe describe what you are seeing?
Yeah, you see halfway the upper arm, you see a tight stenosis, which is approximately 3 centimeters long. And you see some collateral flow as well. So that's an indication that's a high-grade stenosis.
Do you think this might explain the complaints of the problems, the clinical indicators of this patient?
Definitely, yeah. You already saw the prolonged bleeding time after the puncture itself. So yeah, that's definitely a venous outflow problem, and it could be the problem which should be solved.
Okay, thank you. And I think that being in the angiography suite, we will probably do a balloon angioplasty. I'm looking at Dr. Tozzi now. Do you have any? We have to decide which balloon to use before going into different types. Could you tell us your thoughts about the sizing of the balloon?
I think in the native fistula I prefer a size 1:1, and for me the high pressure balloon is a perfect balloon for the preparation of the stenosis. So
how many millimeters would you use in this case?
In this case, I think 6 millimeter in diameter is correct treatment. Normally, I measure before the phlebography with Doppler ultrasound.
Ah, yes. That's always a good thing to do, I guess. Here we have indeed used a 6 millimeter balloon, a standard 6 millimeter balloon by 40 millimeters in length. And Dr. van den Berg, could you maybe comment on the angiography?
Yeah, what you see here happening is what you oftentimes see. Part of the balloon is not opening up. And that is, of course, I don't know how much pressure you're giving at this point. But if you see this, then I
think you don't go further. We have the question just arriving. Yeah.
Okay.
So indeed, the balloon is not inflating fully. So I think that we should now think about our next step. So this is time to vote. What would you do? Would you increase the size of the balloon from 6 to 7? There's high pressure balloons in 6 millimeters. Would you use these? You might also inflate the current balloon beyond the burst pressure to get more power. Maybe you could run a completion angiography and just see what effect this balloon had on the problem, and maybe the residual stenosis is fine and we can leave it like this. Or there's also cutting balloons. One might also use that. Rutger, would you think that simply deflating the balloon and doing a angiography would be okay?
No, that you can do that, of course, but that's not satisfying the problem. You see a very tight stenosis still in the balloon itself. The balloon should be deploying all the way and not have this indentation.
Yes.
So
for a good result, the balloon should definitely be fully
open.
Yes, yeah. And how can we achieve this? I think Dr. Tozzi already told us that he would generally go for high pressure balloons, even as a first step. Is there any room for a cutting balloon, in your opinion, Matteo?
I think the cutting balloon have a problem in the venous vein. It's very produce a damage in the wall, interrupt the internal lamina elastic. So the proliferation of the muscle cell go through the wall in the luminal part of the wall very, very fast. So the damage of the cutting balloon, for me, in this type of stenosis is not correct to the performance. So high pressure balloon reduce the damage of the wall.
Results, please. Thank you so much. So let's see what the audience was thinking. The majority was voting for a high pressure balloon. And I think they go with you, Matteo, and I think I would do the same thing. To increase the size or to use a cutting balloon are also chosen. Let's see, we used, in this case, a high pressure balloon was used, of the same size, still 6 millimeters. Let's see what happens. Look at that. You know, the standard balloons, they have a burst pressure of about 15 atmosphere, and these high pressure balloons, they can go up to 40. So that's a lot more pressure that you can put on these stenoses. And
this case raises the question what pressure is typically required to fully inflate the angioplasty balloon. In this prospective observational study in 230 hemodialysis vascular access stenoses, an inflation pressure of 15 atmosphere was needed in 60% of fistulas and in 50% of grafts to efface the waste of the balloon.
I think this nicely shows that you need high pressure balloons in a lot of cases, and there's definitely an argument for using them as a first balloon. Let's see how it looks like when you did the high pressure balloon. This is the angiography. Is there anyone from the active observers who wants to comment on these angiography images? Jose Ibeas, can I ask you to comment?
Well, nice clinical case. It seems that probably in relation with the pressure of the balloon has been broke the wall of the vein with minimal extravasation of the blood content.
Yes, you see the extravasation of the contrast. So there's a rupture of the vein right now. We should be thinking about our next step. Please vote again. What would you do? Should we compress the hematoma with your hands and wait for it to stop? Should we inflate again a balloon at that same site and use a low pressure prolonged balloon inflation? Hope that it will stop. We can maybe place a covered stent. Or should we go to the operating theater and explore the problem surgically? Please vote. Then it would be interesting to see what you as active observers and as passive observers would choose. Maybe I can ask one of the other people from the audience. I see Karin Bergmans. Would you be able to comment? What would you do in this situation?
Well, there's two things in this case. It's a nice case because there's two things I see. First, the bleeding. You can see the paravasat, as we call it in Germany. So you see this bleeding, and in that case, I would inflate a balloon and wait and see what happens.
Okay.
But the other thing you see, and it's not very clear, but there seems to be still stenosis. So that would vote for a covered stand. After that.
Definitely. I fully agree with you. There still is a stenosis.
Yeah.
Yes.
So that could also be just an effect of the bleeding, I think. But a covered stand is not something I would like to have in this place if it's really the upper arm.
Yes.
So I would initially inflate a balloon and wait and see what happens.
Thank you for your very nice comments. Do we already have the results? Look at this. So we seem to be a bit divided. Beyond some, about half go for prolonged balloon inflation and half go for covered stent placement. We did, in this case, there was a prolonged low pressure balloon inflation done. And I think that the majority of the extravasation is gone. But I think there still is some bleeding going on, Rutger. Do you agree?
I don't. Well, maybe there's a small. I appreciate a little bit of extravasation. Yes, could be also venous outpouching, but I think there's still extravasation going on.
Yes.
Yeah, but more important, as the colleague Karen already mentioned, that there's after the dilatation, there's still resistant stenosis.
Yes. How should we proceed? Again, please vote. Should we accept this small bleeding and think, well, it will stop, and accept the stenosis? Maybe if we continue with this intervention, we only make matters worse. Should we be happy that we controlled the bleeding and stop here? Or should we use a drug-coated balloon in this case, because we need to have these stenosis, we have to treat it better? Placing this covered stent, it was suggested already by Karen just yet. Or should we leave it like this with endovascular and say this will not work, and with endovascular treatment we should go for surgery and do a patch angioplasty and schedule the patient for that surgery? Please vote. I'm wondering, is there any, Matteo, I think you're in the possibility to do both. You do a lot of endovascular work, but you also do surgery. When would you actually do a patch angioplasty for these kind of stenoses?
I think in this beautiful case, we have completely the recoil of the stenosis. So the wall damage and the recoil of stenosis, I think probably the stent graft in this case is a better solution.
Is there any way you would go to schedule a patient for surgery with a simple outflow stenosis and that causes flow dysfunction, or would you always go endovascular?
Always endovascular. Today, I think in these cases, in the cephalic vein, the surgical approach reduce the vein, and the surgical damage probably in the future produce another stenosis. So I think the endovascular is the goal treatment.
Great. Looking forward to what the audience, what the participants think. Can you show the results?
Okay.
Almost everybody agrees we should place a covered stent, and that's exactly what we did here. So we placed here a 7 by 40 millimeters self-expanding covered stent, and I think the result is nice as it is now.
Would you consider a non-covered stent in a case like this? You see reduction of the bleeding already, but you obviously have a residual stenosis that needs to be treated. Otherwise, the patient will not go away from the angio suite with a treated AV fistula problem.
I think that there's no room for bare metal stents in vascular access interventions. This is also stated in the KDOQI guidelines, and when you look at the evidence, it does not do anything better than balloon angioplasty.
Yeah.
So I would like to continue, please, with because this case raises the question of the balloon inflation time as well.
How long the angioplasty balloon should be inflated. In this randomized controlled trial, in 48 hemodialysis patients with 76 vascular access stenoses, a balloon inflation time of 3 minutes did not significantly improve technical success rates and did not result in improved primary patency as compared to 1-minute balloon inflations.
So let's continue to the next case. We have a second case. This is a 72-year-old obese woman. She has a right radiocephalic fistula, and she is 6 months after superficialization of the cephalic vein with a new anastomosis, which is made a little bit more proximal because the original anastomosis was already stenosed, and the vein was also too deep to cannulate because of her obesity. Now, 6 months after this procedure, she has a weak vascular access with poor pulse augmentation, a weak discontinuous thrill and a high-pitched bruit. She has inability to achieve the target dialysis blood flow during dialysis, and her dialysis adequacy, the KT/V, is too low. Excess flow is only 250 mL per minute when measured with transonic dilution technique during dialysis. So a lot of clinical indicators here, and also a very low flow, which I think definitely indicates the need for intervention. We made an ultrasound, duplex ultrasound, before doing the endovascular procedure, confirming the low blood flow and already pointing to the problem that is a juxta-anastomotic stenosis with a diameter of 1.2 millimeters in the cephalic vein. And you can see after superficialization, the vein has a nice depth of only 2 to 3 millimeters under the skin. So let's see what happens when we do an angiography. We have we cannulated the vein in a retrograde fashion and put a catheter around the anastomosis inside the radial artery, and we made a first angiography. So maybe, Dr. van den Berg, could you comment on what you see here in this angiography image?
It's a little bit difficult for me to understand exactly where the stenosis is, but I guess the stenosis is just after the anastomosis.
Yes, I think you can tell by looking at the size of the catheter. It's almost the same size as the diameter of the vein at that point. So this, I think, confirms the findings on duplex ultrasound that there's a juxta-anastomotic stenosis.
Yeah, you punctured countercurrent.
Yes, a retrograde cannulation of the cephalic vein.
Yeah.
You can see the sheath, and you can see the catheter going around the loop of the anastomosis inside the radial artery.
Yeah.
What do you think we should do in this case? And it's time to vote again. It's also voting for different size of balloons. Would you go for a 4 millimeter, a 5, or a 6? And when you think about the previous case, would you start with a high pressure balloon, or would you maybe go for a drug-coated balloon? So Jos, we discussed the issue of starting immediately with high pressure. Would you do that in this situation as well?
Probably not. As you nicely showed with your graphs, a lot of lesions still open up with nominal pressure or rated burst pressure. And it's my experience that if you inflate the balloon slowly, you can get almost to 20 atmospheres with all the balloons, even the standard balloons. And that's one of the reasons why I still use a lot of standard balloons. But I think it's very important that you need to open up everything completely. If you see that it doesn't open up, you can maybe take some more time to let the balloon inflate. But I have a very low threshold to go to a high pressure balloon at this point. And then, as you already showed on the duplex, nicely given where the diameters of the vessel, and if I remember correctly, the vein here at this segment was around 6 millimeters, so I would go for the 6.
Okay. Can we show the results? Oh, look at this. Most would either go for a 5 or a 6 millimeter balloon and use a standard balloon to start with. Let's see what happens. In this case, 2 different sizes were used. There was a 4 millimeter balloon used for the radial artery and a 5 millimeter balloon for the cephalic vein. So we did the 5 millimeter, and this was the result. This was accepted as a good completion angiography, and the procedure was then finished. 3 months later, the problems have recurred. She's again at the angio suite, and this is the way it looks now. I think it's more or less similar, Rutger. Do you agree?
I agree, yes.
So what will we do? Will we choose a similar approach, or should we do something different this time? What do you think? Please vote again. Would you go for... I think we should do something different now. So previously we used a 5 millimeter balloon. Should we go for the 6 millimeter, as Dr. van den Berg suggested we should have done in the first place? Should we go for high pressure ballooning, because the standard balloons don't seem to work as well? Should we use a drug-coated balloon in this case, or should we do bare metal stenting? Well, we've been discussing bare metal stenting in the previous case already, so I think that would not be that good an option. Does anybody disagree? Does anybody use bare metal stents? No?
Not anymore.
Not anymore. I see that Dimitri Dovkansky. I'm sorry, the name is very small in my... I probably mispronounced. I'm terribly sorry for that. So what would you do?
I think I will try first with a standard balloon, and if it doesn't work, I will try with a high pressure balloon.
And sizing 6 millimeter would be okay?
I think so, yes.
Would you have done it in the first place?
Once more, please.
Would you have done a 6 millimeter balloon in the first place? Because we started with a 5 millimeter balloon and accepted the results, and now she's back 3 months later.
I think I will try first with 4 or 5 balloons for predilatation, and then we'll use the 6 millimeter.
Okay. Can we show the results? Now a lot of people are going to use the drug-coated balloon. Very nice.
Interesting.
We did a 6 millimeter balloon, and this is the completion angiography, and I think it looks quite all right. What do you think, Rutger?
You don't see any much of a recoiling, so I would expect this the final result. One small comment maybe on Dr. van den Berg. It's true, of course, a lot of POBA balloons can handle up to 20 atmosphere. The problem is when the compliance of the balloon itself. When you have a normal balloon and you upgrade too much, then you make it like, if it is 6 millimeter balloon, you make it 6.4 or maybe 6.5 even.
Larger and larger.
It gets larger and larger. So that's one benefit of the high pressure balloon, of course. It's a non-compliant one. So that's one reason. If you want to stay up at 6 millimeters, then you use the high pressure balloon.
Very good. We accepted this, and then she comes back 1 month later, not 3 months later, but 1 month later already, and she's completely fed up with all these procedures. And the same stenosis is back, no difference.
Yeah.
What should we do now?
I think that also indicates that it was not the size of the balloon of the initial dilation that caused the restenosis, but just the fact that patients with a dialysis fistula behave like this.
Yes. And we had already a lot of people who would have used a drug-coated balloon in the previous intervention. So I think that it will be very high percentage who would use a drug-coated balloon now. So maybe we can show the results. Yes, almost 90%. And that's exactly what we did. And maybe we should have done this, the intervention before. So let's take a look at the evidence on these drug-coated balloons.
In a systematic review, 11 randomized controlled trials with 1,060 patients were identified that compared paclitaxel-coated balloon angioplasty with plain balloon angioplasty of stenosis in arteriovenous fistulas. In a meta-analysis, primary patency of both the target lesion and the access circuit were significantly improved by drug-coated balloons at 6 months after the intervention, but not at longer follow-up. The intervention rate was reduced by 0.3 interventions per year at the level of the target lesion, but was similar at the level of the access circuit, although this outcome was reported by only 2 studies.
So that's about the evidence on the drug-coated balloon as it is now. This is actually the first meta-analysis that includes the latest New England Journal paper. So this is really fresh from the very fresh. So the final clinical case I would like to discuss with you is on a 65-year-old man with a left upper arm loop graft that presented to our dialysis unit with a thrombosed vascular access. So what we typically do with these cases is to take him to the operating theater. We like to do a hybrid approach when declotting these vascular grafts. So in this case I show you the ultrasound that was done 1 month previously. Obviously, when there's a thrombosed access, it's not much use to do an ultrasound. But you can appreciate here that there's some wear and tear of the vascular graft at the venous site. And there's a stenosis just beyond the venous anastomosis. And both the arterial and venous anastomosis are created in the axilla. So this is how it looks after surgical declot. We first take a look at the arterial side, which looks, I think, pretty much all right. And then we take a look at the venous side. And you can appreciate that there's a little stenosis, I guess, there, which we dilated with a 6 millimeter balloon. No use to do larger balloons because the diameter of the graft is only 6 millimeters. And this is how it looks like. I think that the result in the graft is okay, but take a look at the outflow vein. Matteo, could you comment what you see there?
Thank you, Martin. It is a typical stenosis of the venous anastomosis of the graft. So I think predilate with a high pressure or a focal force balloon and then drug coated. Probably is in the first time after thrombosis is my first approach.
Okay. Let's see what you can choose here. So you would go for a C. Let's see what the audience will do. Standard 7 millimeter balloon, high pressure 7 millimeter balloon, drug coated 7 millimeter balloon, bare metal stent or a covered stent. Is there? I see that Nuno Rosa. Would you be able to comment a little bit on your choice? What would you do in this case?
We usually do a 7 millimeter angioplasty balloon standard.
And then if you find that the results are okay, then you leave it like that?
Yes.
That's good.
For sure.
Excellent. Can we show the... And do you have good results with that then? No early rethrombosis?
If it's the first time that it's the first thrombosis, normally that's the procedure.
Okay, great. Thank you for your comment. Very nice. Can we show the results, please? Ah, look at this. Most of the people would use standard balloons, high pressure balloons, some a drug coated balloon. No stents are being used. And we actually, in this case, a covered stent was placed. And you can see the 88 by 60 millimeter self-expanding covered stent placed just at the level of this anastomosis. And there you can see how we post-dilate the stent with a high-pressure balloon. And then the completion angiography, I think, shows a very nice result. And please allow me to...
In a systematic review, 6 randomized controlled trials with 900 patients were identified that compared covered stent placement with balloon angioplasty of the venous anastomosis of arteriovenous grafts. In a meta-analysis, primary patency of both the target lesion and the access circuit was significantly improved by covered stent placement. Furthermore, the access circuit intervention rate was 0.7 interventions per year lower when a covered stent was placed at the venous anastomosis of arteriovenous grafts.
So there seems to be some evidence for placing covered stents in this particular situation, which does not happen very often, because obviously we always try to use autologous fistulas, preferably than using arteriovenous grafts. So I think that we will wrap this case-based discussion up. I hope you enjoyed having this interactive way of talking about endovascular interventions for vascular access flow dysfunction. I would like to move on to the final part of this workshop, which shows in depth both the properties and the clinical outcomes of this new Aperto balloon, which has the very nice property that it's both high pressure and drug coated. So please pay careful attention to the next presentation, which finishes the workshop.
This presentation was made by Dr. Matteo Tozzi at the University of Insubria at Varese, Italy, who is a consultant for CardioNovum.
Welcome, ladies and gentlemen. It's an honor for me to speak about properties and clinical outcome with the Aperto balloon in EVC Congress. Aperto drug-coated balloon is a new generation paclitaxel high pressure balloon for the treatment of stenosis in EVCs. The drug is the paclitaxel, 3 microgram millimeter square, but the revolutionary technology of the Aperto balloon is SafePax matrix. Is a third generation non-crystalline matrix system based on polymeric ammonium salt excipient for paclitaxel. The system provides anamorphic coating but prevent the crystallization of paclitaxel on the surface of balloon and minimize the drug loss during manipulation, navigation, and inflation of balloon. The lipophilic characteristics of matrix maximize the drug uptake on the target area of the vessel wall. The surface of the Aperto balloon is transparent without powder. Is the aspect of new amorphous coating. In the microscopic evaluation, we see the surface regular and amorphous. Elastic polymeric excipient reduce the mechanical stress, and this feature allows us to maximize the drug that reach our target lesion. The last high-level evidence for Aperto DCB treatment is published in American Journal of Kidney Disease in January 2021 by Professor Yankee In. The title is Efficacy and Safety of Paclitaxel-Coated Balloon Angioplasty for a Dysfunction Arterial Fistula Multicenter Randomized Controlled Trial. The primary endpoint of this randomized controlled trial is the primary patency of the target lesion, and the secondary endpoint include device, technical, clinical, and procedural success. In the consort flowchart, we see the total number of patients, 161 in their arm of DCB, 78 patients treated in the control with high pressure balloon 83. During the procedure, they perform the preparation of vessel with angioplasty and then randomize DCB versus high pressure balloon. The primary endpoint is achieved at 6 months, statistical significance and primary patency of the target lesion, 65% of the DCB group compared to 37% in high pressure balloon group. The survival curve for freedom from clinically driven target lesion revascularization showed a statistical difference at 1 year in favor to DCB. Another survival curve for freedom from clinically driven target shunt revascularization showed a significant difference at 1 year of follow-up, also in favor of DCB treatment with less number of retreatment, 0.85 number of retreatment for 1,000 days fistula in DCB group compared to 1 to 29 on 1,000 days fistula. The secondary patency, it's not significant differences, 90% for DCB and 80% of high pressure balloon. So in conclusion, after this very interesting randomized controlled trial, it's possible to speak about the safe of aperto DCB PTA, because was no significant difference between the two groups in the rate of adverse event. Aperto DCB PTA is an effective procedure because in the DCB group, we see better primary patency compared to high pressure balloon, and aperto DCB PTA save the vascular asset of patients long time, because we have a low intervention rate, 0.85 number of retreatment compared to 1.29.